My pleasure to welcome Terry Manolio from the National Human Genome Research. I think most of you know, and she's going to give the physician's view for Stevens-Johnson syndrome.
Thank you very much. Let me just get wired up here. Hi, so as she said, I'm Terry Manolio. I'm delighted to be here. And even though it is probably one of the hottest days you've had in Philadelphia, it's cool compared to Washington. So I'm glad to be here for that reason as well. I'm going to step in front of this because I never like having these huge barriers between me and an audience. So be aware, I'm out to get you. So I was asked to talk about the physician's view. I'm a practicing physician at Walter Reed National Military Medical Center, in addition to leading the Division of Genomic Medicine at the Human Genome Research Institute. Many, many years ago, when I was an intern, my first encounter, my only, thankfully, encounter with a patient with Stevens-Johnson actually was a 50-year-old woman who was taking spironolactone for hypertension. Not a commonly implicated drug in this syndrome, but that was about all that we had to ascribe it to. And can you hear me? Put it way up here. Okay. Is this better? Yeah. So raise your hands if you can't hear me, or holler at me, or whatever. At any rate, she came in with a generalized rash that began to blister, and over the course of 3 days, she sloughed almost her entire skin surface, as well as her respiratory tract, her GI tract, her corneas. It was the worst thing I've ever seen. So fast forward then several years, many, many years, I came to the NIH and moved to the Genome Institute, where we have a series of meetings annually about sort of hot topics in genomic medicine. And we had this one, sorry. And these are all, by the way, categorized or cataloged on our website. If you're interested in looking at them, we hold them, as I said, about every year. And the sixth one that we held back in, I'm not even sure when it was, 2000, no, I'm not sure what the date was, but several years ago, maybe about 2015, 2014, was on global leaders in genomic medicine. So we tried to bring together all of the groups around the world that were doing implementation of genomics. At the time, there was almost none going on in the US, but there was a lot, surprisingly, going on around the world. And the goals were really to sort of find out what is going on and then see if we could develop some collaborations. And at that meeting, I heard about this very interesting program that was going on in Thailand. Thailand, I wouldn't have thought would have been at the forefront, but they have a high risk for Stevens-Johnson, primarily from carbamazepine and their high rate of allele frequencies for HLA-B1502. So they had implemented a program, and Wasan Chandratita was at the lead of this. He described I would just mention the incidence of Stevens-Johnson had been going up, and then around not too long after our meeting, started coming down again, which was very cool to see. He described it. We had interviewed many who survived it. They said their bodies spitted rotten flesh and blood from their mouth. They felt their bodies were burning and that someone had poured acid into their eyes. The pain was so extreme that they wished to die and they could not. These are the only awful pictures I will show you, but it is truly a horrible thing. So after that meeting, realizing that they had actually done something that could reduce this, we held a meeting specifically on Stevens-Johnson toxic epidermal necrolysis, invited the Thai group as well as many from Southeast Asia and around the world, and learned about both the research that was going on and the research that was not going on in the US. We were supporting very little of it at the time. So we tried to stimulate that. We identified a series of research directions. A variety of groups have gotten funding to do this, some of it from us, some of it actually from patient and patient advocacy foundations, and you'll hear from one of those patient advocates very shortly. So a physician's view, what I thought I would do is basically show you what most physicians know, or can know about Stevens-Johnson, basically taken from the data source UpToDate, which is what all my residents use, and I have to admit what I use when I see a case, because it's very quick and you can scan it easily. So it's a severe cutaneous adverse reaction to viruses or drugs characterized by extensive necrosis and detachment of the epidermis. It looks like this histologically. You would think that this is just an artifact, but it's not. It's actual separation of the superficial layer of the skin. And this is what it looks like. I lied. This is another awful picture early in the morning. But skin just comes off in sheets. It's really awful. Mucous membranes actually are affected in more than 90%, including the eyes and the genitalia. And patients who survive this often have very severe complications from that involvement. The two syndromes are a continuum. They were described by different physicians at different times, but they're classified by the percentage of the skin body surface area that's detached. If it's less than 10%, it's Stevens-Johnson. If it's more than 30%, it's TEN. And if it's in between, it's described as an SJS-TEN overlap. Physiologically, pathologically, they don't seem to be terribly different, although the complications are different. The mortality goes up the greater the skin percentage involvement. The incidence is estimated at 5 to 6 cases per million per year, with the milder or the less extensive involvement being the most common. Multinational studies estimate the median age is early 50s, and it's more common in girls and women by a ratio of 2 to 1. It occurs in children, sometimes more commonly precipitated by viruses in children than it is in adults, but it can be caused in both. Risk factors include a number of things. Patients with HIV, especially if it's progressed to AIDS, have a 12-fold risk. There are high-risk drugs that are used for treatment of AIDS, both nevirapine and the antituberculous drugs that also often accompany it. This was a particular problem for the Thais because they have a lot of patients with HIV. They also have a lot of TB. And when they get a patient with SJS, they don't know which drugs to stop. It can be as many as 8 drugs that could be implicated. And so that's a challenge. Opportunistic infections in HIV treated with these drugs will also can precipitate it. Connective tissue disease has a 2-fold risk, although conditions like lupus can mimic it, so they can be hard to tell apart. Malignancy has a 30 to 60-fold increased risk. This is relatively new to be identified. Common triggers are trimethoprim sulfa and phenytoin, but also immune checkpoint inhibitors, which are being used increasingly now for treatment of breast cancer and other things. Older age, Black and Asian ethnicity are also risk factors. Increased drug doses and impaired renal function, probably because it increases the systemic exposure, but that's especially true for allopurinol-induced SJS/TEN. Mortality for acute episodes is overall nearly a quarter, ranging from 12 to nearly a half, and increases with increased severity, as I mentioned. And if you follow these patients over 1 year, actually a third of them suffer mortality. So it's a very serious condition. On the etiology, a number of high-risk medications have been identified. Allopurinol, lamotrigine, allopurinol used for, I probably don't have to tell you guys this. So you know what allopurinol is used for better than I do. Lamotrigine is an anti-seizure med, other aromatic anticonvulsants, the antibacterial sulfonamides, oxycam or cyclooxygenase 2 inhibitors. NSAIDs, those drugs, and as well the immune checkpoint inhibitors. The timing, usually the causative medication has been started within 1 to 2 weeks of the onset of the rash. It's rare for it to be have been started more than a month prior to onset. In about 15%, there's no clear causal drug. Possibly mycoplasma or other bacterial or viral infections can be responsible for this, especially or more likely in children. There are some attributions that are somewhat controversial: chemical exposures, complementary and traditional medications, vaccinations, foods. And some are just idiopathic. So far, we don't know. Predisposing haplotypes in certain ethnicities. There are predisposing HLA haplotypes in some ethnicities, particularly in Southeast Asian. They've been identified, but in other groups as well. There's one in European ancestry individuals, carries a lower risk. But these have been the basis for pharmacogenetic guidelines, which, as you know, CPIC has provided. The clinical presentation often is prodromal symptoms of malaise, fever, myalgia, sore throat, conjunctivitis. There may be painful rash or erythema developing. It starts on the face and the thorax and spreads elsewhere. It's usually symmetrically distributed. It begins with ill-defined coalescing erythematous macules, so just red spots, evolving over 1 to 2 days to develop a dusky erythema, which distinguishes it from other dermatologic drug reactions, which I won't list here, but particularly erythema multiforme is one that can be hard to distinguish early on. There are purpuric spots and flaccid bulli, another distinguishing characteristic from other forms of drug reactions. It then progresses to extensive sheet-like detachment and erosions. Skin tenderness is prominent and strongly suggestive of SJS/TEN. The acute phase lasts from 7 to 10 days, usually, especially if the drug is started as soon as it begins. Then it sort of arrests, and then slowly they re-epithelialize. And during the active phase, these are very much like burn patients. And so you have to treat them for fluid and electrolyte imbalance, increased metabolic demands as they're trying to keep up with their fluid loss. Sepsis, it's very easy to get infected. Hypothermia, obviously, they have no protection for heat loss, organ decompensation, and death due to extensive detachment. And this is just one indication. It does get better, so you can see that it does heal over time, but if they survive. Extracutaneous involvement can be, as I mentioned, quite severe in the post-acute phase, so mucosal involvement. Basically, all mucosal surfaces can be involved. This was in my patient. It most often includes the mouth, the oronasopharyngeal cavity, and anogenital mucosa can also be involved. It can include the epiglottis and the larynx and can threaten the airway, so sometimes these patients have to be intubated. Genital erosions and pain can cause urinary retention, labial and vaginal adhesions, which can be disabling later on in life. The eye involvement is very common. Typically, it's conjunctivitis, but it can actually progress to pseudomembrane formation or even corneal perforation. The head of the Eye Institute, we involved several of our institutes. One of the challenges with SJS/TEN is that it doesn't fit neatly into any specific NIH institute. In a way, that's a good thing. It has many parents. What happens is the cornea sort of becomes sticky, and anything will cause them to either slough or perforate. The ocular involvement is the strongest predictor for, as you might imagine, long-term ocular complications. Up to 3/4 will have chronic eye sequelae, which can be lid and eyelash adhesions, which you wouldn't think would be that bad, but actually they can then dig into the cornea and cause corneal abrasions and other problems. Corneal scarring obviously can interfere with vision and reduce visual acuity, even blindness. Other organs are affected with acute kidney and lung injury, GI involvement and ulceration, liver injury, just about every system, hematologic abnormalities, bacteremia, and sepsis. So this is a generalized systemic disease, and it's very severe. The management, unfortunately, at present is typically supportive. It's, obviously you stop the potentially causal drugs. They often are moved into burn units, and some of the more creative research has been done in collaboration with burn units. Most major burn units will get 1 or 2 of these patients a year. Fluid and temperature management, nutrition is a big issue in these patients. They're losing a lot of protein along with the skin. Pain control, also a big issue. Prevention and treatment of infections, prevention and treatment of urogenital lesions, which often involves dressings as well as topical steroids. Ocular lesions also, corticosteroids. Amniotic membrane transplantation for perforations has worked reasonably well, and so that is a newish treatment, although it was going on even 10 years ago. There don't appear to be clear advantages to systemic therapy with intravenous immune globulins, which are often given for acute autoimmune phenomena, or with corticosteroids, even though they're still commonly used, or cyclosporine. There's some evidence on either side. And the possibility that tumor necrosis factor inhibitors such as infliximab and etanercept, they're being tested, but the evidence, again, is not strong. So One of the very promising things that has occurred in this field, at least for this particular drug, and now stimulating research elsewhere, was this report from Chung et al. In 2004, demonstrating that HLA-B1502 was present in 100% of the carbamazepine-induced Stevens-Johnson syndromes that they saw, but only 3% of those who were tolerant to the drug, and about 9% of the general population suggested that as a risk factor. They then published a different group published a study looking at another HLA region, this time HLA-A locus 3101, showing hypersensitivity in Europeans. And you can see here the risks that were assessed for SJS/TEN 26-fold in those carrying that abnormality. And then there are other forms of dermatologic hypersensitivity, and those were at 9-fold increased risk. The FDA issued a warning to physicians to be aware of this potential and asking clinicians to determine if the patient has ancestry across broad areas of Asia, which required, this is an editorial on this requires clinicians to know what Asian ancestry means and use a consistent, reliable method to figure out which patients have this ancestry. Obviously, all of you are in the genomics field, you know, why not just test the gene? Because that's really what you want. You don't want to necessarily know what region they came from. Wouldn't it be better to have your electronic medical record system say, this patient carries the HLA-B1502 allele, a known risk factor for carbamazepine, when you go to prescribe carbamazepine or other drugs to which a patient may be sensitized? So that's the dream. That was the dream in 2015. It is still the dream, at least in my hospital. We don't have this kind of setting. At the clinical center at NIH, we do have this kind of clinical decision support, so that's a good thing. But still getting the testing done, getting it back, getting it into the medical records are all barriers that I think you'll hear about today. The FDA has revised its warnings. This is a boxed warning about serious and fatal dermatologic reactions. The risk in some Asian countries estimated to be about 10 times higher. And they note that patients with ancestry in genetically at-risk populations, again, still identified by ethnicity primarily because we don't have more broad screening of these variants, should be screened for the presence of B1502 prior to initiating treatment with, this was the brand name, with carbamazepine. So we're getting there. The CPIC group, which you've heard from and will continue to hear from today, published an update that one of the first guidelines I think you all put out was for this, the B1502. But in 2017, that's the most recent update that are those annoying updates that you then have to change your CDS for. But at any rate, this is the recommended therapy from that table. I can tell you that, unfortunately, at my hospital, not many people have heard about CPIC. Even the pharmacists haven't, which is scary and disappointing. I mean, they hear about it from me, but but it would be nice if it were a little more broadly known. And I am delighted to see that in the physicians' continuing education and in the exams we have to take to maintain our certification, there are now coming in recommendations for this and things that one has to know. I hope that's in pharmacy boards or pharmacy recertification, and some of you may be involved in setting the guidelines for those, and hope you will put them in. This was a very, what we thought, a very creative thing that the TIEs had done to basically notify patients and clinicians of the presence of these pharmacogenetic variants. And so you can see this is in Thai here. I can't read it. You notice that they're 500 years ahead of us, and that's about what I would say they're doing in pharmacogenetics, but be that as it may. So the patients get this. It looks like a credit card, except that it's this bright purple, like my shirt. And it suggests there that this person has B1502, which is high risk to develop this severe skin disorder, and gives information for contacting the PGX laboratory at this particular hospital. This has since spread nationwide beyond that particular hospital. This same sort of approach was used with sort of an upscale QR code, like the one we scanned when we came in this morning, that the UPGX, the Ubiquitous Pharmacogenomics Consortium, when they did their PREPARE trial, they developed this approach to scanning a QR code, and then this comes up on your phone, and then it gives the drugs to which a patient may be sensitized. So, somehow I got on the automatic route. So let's see if I can go back. Probably not. Yes, I can. Okay, great. And evidently in the Netherlands and in some other Scandinavian countries, you can get this even if you're not part of the study. You can get this kind of a card, and pharmacists know what to do with it, which is really cool. Economic evaluations in Thailand and elsewhere have shown the excellent cost effectiveness for this in terms of quality adjusted life years. The usual estimate in the U.S. is if it's less than $100,000 per quality adjusted life year, it's worth doing. And you can see here it's very cheap, but this is in Thailand, so I'm not sure how that translates to us. Maybe we'll hear something about cost effectiveness in the US, and I think some of those studies have been done. The challenge is that it's less common in the US by quite a bit than it is in Southeast Asia, and so cost effectiveness is going to decrease, or the costs will increase to find a single case since there aren't as many of them. These are the data from Thailand since that original meeting that I had shown you. So you can see the climb these are from the Ministry of Health. The FDA issued an alert in 2007. I love this. This is from the Ministry of Health here, and they actually admit to brainstorming in a government agency. So I thought that was just great. And they then studied it, demonstrated cost effectiveness. They've implemented national testing in 2018, and the rates went down even more dramatically than they had previously. So really a success story in that part of the world. This, again, is showing cost effectiveness. They screened almost 5,000 patients. None of them developed SGS-10 versus about 10 that would have been expected. This is just giving an idea of the global frequency of drug-specific, at the time, the drug-specific HLA alleles that were known, the major ones at least. And I think this shows why we're having some trouble getting this adopted in the US. So this black one here, if you see down there, that one is HLA-B1502, which is the sensitizer to carbamazepine. And if you look in US Caucasian, an unfortunate term, and US African American, very, very low frequencies, as opposed to Singapore, where it's greater than 10%, Singapore Malay, where it's greater than 20%, and other parts of the world. U.S. Asian populations, though, are about on par with some of the native Asian populations. So this has been one challenge to getting traction for this. On the other hand, we at the Genome Institute, because we look at the ohm, have always felt that doing one allele at a time or one gene drug pair at a time is the wrong way to go because they're so rare. And really what you need to do is test them all, which we can do very easily. Well, very easily. Marilyn will tell you how easy it is to get it from sequencing data. But at any rate, we can do it, and it may be something that we can implement before too long. Why did I show you this? Because one of the things we would like to see happen on looking at an omic level or a systems level is actually some kind of systems integration of this kind of testing, which I know is being done at some very advanced places like St. Jude and others, but unfortunately not nearly enough. And so our 14th meeting, which was actually held in 2022, focused on learning healthcare systems, which are basically systems that implement a change and then study that change as it's being implemented in patient care as a quality improvement project to learn from, what impact did it have? Should we modify it in some way to make it more accessible or acceptable to patients and clinicians? Then can we re-implement it in a virtuous cycle of learning, hence learning healthcare systems? And our objectives there were to try to figure out, what are the things that are currently going on in learning health systems? What are the barriers to doing this kind of implementation? And then can we bring together some of the leaders in this area and actually have them share their approaches in such a way that they could be transportable to places like Walter Reed, sorry, don't record that, or to other hospitals that are not doing this in a relatively easy way. We have issued a solicitation. It's soon to be awarded for a network of genomics-enabled learning health systems. So the data are continually monitored, and you can see here some examples of that. And that was our solicitation and basically the goals of that. So there is, we think, some light on the horizon, especially as these kinds of solutions become identified and get sort of road tested in various systems to be able to implement them. So I think at that point I will stop. I'll be happy to answer any questions, and I thank you for your attention.
Any questions? I don't know if the mic's on. Do I need to? Did he show you? Okay. She's got questions.
Thank you for your presentation. I have a quick question regarding implementation of this HLA star 31 or 15. For example, in a clinic setting, if you have a patient coming in and with the Lamictal and has a rash, would you recommend, of course, we never have that information available with those because there's some crossing with the other, and because, for example, carbamazepine is now using for neuropathic pain and off-label use and so many things. Do you recommend and then pharmacogenomic testing for someone who has that kind of a rash?
So I'm probably not the best person to comment on that. Others may have their own views. Deepak probably would have some thoughts. I guess what I would say as a dumb internist is, it might not hurt to look for that. You're still going to stop the lamotrigine anyway. The question is, might this have implications for family members? So if you find it, would you want to test other family members? Even if they have it, they don't necessarily have the sensitivity to it. So there are cases where people have horrible Stevens-Johnson on carbamazepine, and they have relatives who've been on carbamazepine for a year, have the same variant, presumably a very similar genetic background, and don't have the condition. So what would it mean? It's not clear. You could do it, but it's so hard to do, I would probably pay attention to other things, honestly.
Would you add it to their allergy list, or how would you?
You definitely add it to their allergy list, yeah.
Would you add carbamazepine, Lamictal, everything, or would you just add one?
I'm not sure I'm qualified to say. The gentleman sitting between us will be better able to come. Do you want to comment, Deepak? There's a microphone.
I mean, there's lots of different approaches. I think we would typically not put it in the allergy list because, especially if it's a drug they haven't been exposed to, but maybe find somewhere else in the medical record that you could put it, and that could be used to fire clinical decision support. But we, at the VA at least, have not been putting it in the allergies per se. We've tried to find other places where we can put it.
Interesting. So if you had somebody with lamotrigine, presumably SJS, you would put lamotrigine in the allergy list, but not the others. Okay. Yeah. Sure.
Terry, great talk as always. I wanted to just pick on one little thing that you said about not doing single gene testing. Okay. Could you just give us a little bit more of an opinion commentary?
Yeah, no, that's fair. Singleton testing.
I like the idea. So
I'm sorry, you like?
I like the idea, so I just want to hear your opinion.
Oh, it's my rationale for that is mainly that singleton testing, so testing single genes or single variants, is almost as expensive in the U.S. marketplace, maybe not elsewhere, but in the U.S. marketplace, as testing all of it. And we know that 99% of us probably all of us, have variants that sensitize us to certain drugs, some of which we may never see, but many of which we will. And so having that information, if we had medical record systems that could hold onto it for our lifetime and would move with us from one system to another. I mean, all of these are dreams, but they're not unattainable dreams. Then I would say, get it all at one time, preferably when you enter a medical system, again, something that is being tested at Geisinger and elsewhere, and then have that follow you so that when you do get exposed to allopurinol or you do get exposed to clopidogrel or whatever, that information is available to your clinician and they can modify your drug dose or selection accordingly. Is that what you were hoping to hear?
I share the dream. Thank you.
Great.
I actually want that voice clip played on the internet with your name and picture and credentials underneath it. But I'm Christine Ashcraft from UScript. There was a 2019 publication looking at a large U.S. cohort for HLA-B 1502 positives 48% were Asian, 22% African American, 17% Caucasian, and other 13% when confirmed with sequencing. And so I think the FDA black box warning as it stands is a public safety issue, in my professional opinion. Has there been any outreach to the FDA, or is there anything we can do to take away the, I think, misguided information on only focusing on patients of Asian ancestry, although they are slightly higher risk?
No, that's an excellent question. I think the FDA is responsive to public concerns, probably as responsive to you as they are to us. And I'll say no further about that. But we can try. Rob Califf is an old friend. There are many things that I think we would like to see them do. But I agree with you that that is a major shortcoming of that boxed warning. It is at least there, so that's something. And I think we would all agree that you know, if you can't get a physician to do anything other than focus on Asian ancestry folks, at least you've made some progress, because they are at tenfold higher risk. But I agree with you. And probably if you got some of the CPIC might be able to, or other pharmaceutical pharmacy groups to engage the FDA, and I could probably try to help you find who that should be. Again, that may be something that DPEC knows. No, you don't deal with the FDA. One federal is enough. Yeah. I hear you. I hear you. Yeah. Yeah. No, but that's an excellent point. So we should probably talk later about doing that. Sure. Sure. Here, let me.